At the outset, I'd like to thank Dr. Venkatesh and Dr. Naveen for this opportunity, and the entire team, Arvind, and it's quite fun. It's a privilege for me to be here in this gathering. And my apologies because I was supposed to be present live because of some circumstances. I'm presenting this online. My apologies for the same. So this is a topic which has fascinated me for long because from my younger days, starting from our undergraduate PG levels, it has been already ingrained in our mind that, some surgeons are just born great, they have it, and some of us don't have it. So this was something which I was fascinated about, and over a period of my 20 years of my career, try to really question this. So my argument is, are expert surgeons born or made? Now, because surgical training in the world over, it's extremely tough for the young kids nowadays. And so much of a psychological pressure is on them. They don't have the belief system in themselves whether they can make it or not. So the same feeling which I had when I was doing my residentship. So just want to revisit my thoughts which were there, and I dedicate it to my teachers who have held our hands and taught us all these things. See, one of the greatest, what do you say, myth or a reality, I'm not sure, is the surgeon's hand. You're always, in a commonest language, they attribute everything to the surgeon's hand. They say, you must have heard, all of you, that surgeon has got magical hands, he has he's gifted hands, and all those things. So this is very fascinating for me. Is it really the hand which matters? In typically, it is called as Hatkun. In Karnataka and my Kannada language, we call it Kaiguna. Similarly, in Tamil, we probably call something Chai Gun or something like that. So you must be hearing, patients will come and tell you, it's your hand skill or my destiny. There's a common phrase which I encounter. Now, is it really true? That's what I wanted to, inquire about more. So when I Googled it, you know what? I somehow found out this fascinating picture wherein, the God is there, he's guiding the surgeon. And believe me, the surgeon also happens to be an eye surgeon. So it is just comforting that, eye surgery is probably the most skillful surgery which we can have. So we require the divine intervention. So there's a common myth, that a common belief system, I should say, that, somebody is blessed with the hands. So is it really the hand or something? That's what I want to inquire. The second aspect would be, you're always told that fellow is a good surgeon, somebody else is not a good surgeon. These are the things which common come into discussion. So he's a very good surgeon. Nobody tells the nuances of it. Why is a good surgeon? Nobody talks to you about it. So the belief is that either you have it or you don't have it. That's how it is. And that's quite disheartening for a lot of people, like, who have lack of self-belief. They start believing themselves that, I may never cut it as a surgeon itself. But believe me, what differentiates the great surgeon is the mind and not the hands. So this one clarity of thought, I want all the young surgeons here or budding surgeons, the Gen Z surgeons has to remember here. The surgeon has become more skillful, more expert, more great just because he's trained his mind to anticipate, plan, analyze, and implement appropriately in the right time. That is the reason why he has achieved that status. So the bottom line here is, dexterity is not the most critical thing, which is overrated. Dexterity, especially for eye surgeries, it's not the most critical thing. You need to have, but intelligence, knowledge, creativity, courage, and perseverance need to get up when you fall. All of us have complications, and we need to learn from them. These are more important than just having extreme good dexterity. The most important aspect is good surgical judgment, and this is not taught to us. Among all these three, if I would rate, highest is the good surgical judgment. Unfortunately, we believe that only experience can teach this. And this happens to be the most critical aspect. So if you correlate all these things, what is the most important thing to train is to train your mind. That is one thing which you need to train, and which is not really much spoken of. So the bottom line of my introduction is, surgery is done with the mind and not with the hands. Let us begin this. So now I can argue that surgeons can be made. So it is not that only surgeons are born great, either you can be or you cannot be. It's a myth. So let me take you through this graph, okay? Assuming there are 100 surgeons here. So I would like to divide them into these sections. 3% of them are extraordinary. They're blessed. There's no doubt about it. It is a fact. They might be having extraordinary intelligence. They have better vision. They have better, maybe you can call it a 3D or 4D supervision. and their hands are stable, maybe have a stabilizer attached to it. God has given to them. Fine. The second, third, 3%, they don't intend to learn. They don't learn surgery because they don't intend to learn at all. Their attitude is pretty bad and they can never be surgeons. But the majority of us, including me, follow in this 94% of the people who are average and maybe marginally competent. But my goal is, if we can teach them appropriately, can we squeeze these 94% of average surgeons into the top 10% of the surgeons? Is it possible? It is possible. Of course, the surgeon in question should have the right attitude. And if he's lucky enough and gets the proper guidance, definitely the average candidate can squeeze himself or herself into the top 10%. Any learning curve has this graph which is there. And we need to understand that. Once we begin with, when we're absolutely clueless of what we are. And that time, that is okay, fine. When you just entered your first day of your college residentship, it is like that. But then the dangerous phase is the second phase where you're confident, but you really don't know what you don't know. And this is the most dangerous aspect of it. Your morals are very high, but the sad tragedy is you don't know how incompetent you are. And then there will be a fall. There will be a fall which is quite harsh. And then you become realistic. And that is a stage where actually you know how incompetent you are. See, knowing what you don't know is probably the most important step, which actually helps you to learn. The learning actually begins here. And now the graph increases. So many times what happens when you fall from the second stage to the third stage, people don't get up only. They'll be so discouraged, they quit surgery. That's what happens. Now, over a period of time, you have a long journey from becoming a novice to an expert. Over a period of time, your competency level increases. But what is more striking is the quality of your decisions which you take intraoperatively, that becomes better and better over a period of time. So that is the one thing which changes over a period of time.
Supposes that we go.
And the journey to master, it is not a straight line. You always have a step and then you go ahead. So you begin by being conscious about your incompetence and then gradually try to improve upon your incompetence and go over to the stage of mastery. So don't be, fooled yourself. Because I am involved in training a lot of these young surgeons who just finished their residency. The biggest problem which I realize is they are not sure about what they know. They believe that they are already competent enough is the biggest drawback which they have. So first, be very brutally honest with yourself and understand what you know and what you don't know. So once you're conscious about your incompetence, then actually the learning begins over a period of time. So another common question which is asked is, how much time does it take for me to reach a stage of mastery or expert? Well, the answer is it depends. It depends on so many factors. But the most important thing is on the surgeon himself or herself. Look in the mirror. The person who is going to decide the rate of learning is himself or herself. It depends upon how passionate you are, how dedicated you are. That's the one thing which is going to decide you. Now, as mentors, as teachers, can we accelerate the learning curve and can we make it much smoother? That should be the thing which we should be discussing as teachers. See, learning surgical skills is daunting, okay? So I'd like to divide this into 3 parts, which would make the learning much more easier and quicker. The first aspect is the motor skill, that is the dexterity part. Here, an external influence cannot help. You have to figure it out yourself. The only answer to it is practice. You have to keep practicing and practicing. That's the solution to it. The second most important, which has to be mentored, is by the teachers themselves. Because surgery, there are a lot of secrets which have to be shared to the students. And here the mentors cannot be miserly in sharing the secrets. So the common attitude is, I have taken 10 years to figure out one small tip. Why can I share it to the newbie just like that? That's the common attitude which we have. So if that is there, the learning curve becomes a little bit more prolonged. The third aspect, the psychological aspect, which I want all the mentors to share with the students, is decision making. Because when we finish a product, we are teaching somebody and he's out into the open, practicing on his own, and he lacks this basic thing like decision making. That is what we don't teach in our medical schools or during our period. So how to handle a crisis situation? This has to be taught by the mentors to think. It is not that during his tenure or her tenure, she's going to expose to every sort of complication. So it is better that you have a complication, write down everything. You have a game plan ready when you actually experience that complication. I don't want any of my young colleagues to go and be the Abhimanyu. It is not the place to be. You go in and you don't know how to come out. That should not be the situation. So as mentors, it is important for us to ensure that he's well rounded off. So you should imagine every possible complication situation that you can have when you're alone, and you should have a game plan ready. Just for the simplicity of the sake, let me take the example of nucleus drop. You've done your cataract surgery fellowship, you've gone into a private practice, you're going to do it, and you never had a nucleus drop in your training period, or you're not bothered about it. Unfortunately, you have it. And then the panic strikes you so badly that you end up doing a lot of the mishaps keep on continuing. So, for example, how do you write down a protocol if you have a nucleus drop? So you should have brain-hearted this before even you have your first complication. This is what I would like you to do. First thing is always stay in the present. The nucleus is sinking, staying in the. This is the most difficult aspect. It's very easy to say it done, but probably the most difficult aspect. What will be thinking? What will I go and tell the patient? What will the patient tell? These are thoughts which are running in your head crazily that time. So you just divide into two aspects. One is the psychological aspect of dealing with the patient that you don't get into your head now itself. Now, intraoperatively, what are you going to do it? That strategy should be very clear. I am not going to fish for the nucleus. I'm going to minimize as much maneuvers as possible because I don't want a corneal edema to happen. Close the case as early as possible. Anti-vitrectomy, if it needed, it has to be done immediately. And whether to put an IOL or not depends upon your previous consultation with the retina friend. And you should have a good retina friend. So these are the intraoperative strategies here. Don't prolong the surgery sitting there trying to fish it out, because when your mind is cloudy, you don't know what to do. Now, coming to the dealing with the patient, you have to by heart these phrases also. You can't be very clumsy when you're communicating with the patient. The cataract could not be removed, the phase which you have to use, because it was not accessible. It was behind. But don't worry, it will be taken care by another friend of mine. He has the infrastructure and the skill level to do this. And you should, more importantly, in Indian circumstances, you should have a definite financial plan of the situation. You just patch the eye and say, go off wherever you want. No, you cannot do it like that. And you can arrange the nucleus management, the VR friend, and it has got excellent outcomes. Now, if you already know how to deal with this, the psychological aspect, non-clinical aspect, and the clinical aspect, whenever you encounter such a complication, you're already well-versed with all the things. So you don't panic. Your decision-making is very sound. And the patient also, when you sound very clumsy when you communicate with the patient is going to be much agitated and the situation is going to be worse. So these are some of the things which you should be knowing beforehand, even if you have first complication. And here, the role of the mentors is enormous. Like even how you communicate with the patient. These are not things which are commonly taught to our younger colleagues. Coming to the next aspect, mentoring, surgical secrets. You have to share the secret with the surgeon, because it takes a long time for them to learn one small trick. In our days, without the internet, it used to take 1 year, one conference to learn one small tip, like, using of a trypan blue. Trypan blue also we came to know later. Those are small things, but nowadays the Gen Z is blessed with the information. It is available by the second. Only thing is how you use it. That's the challenge for the younger generation now. Well, the traditional approach of teaching, what we are all aware of, you as mentors, we expect the students to observe the video. Your surgeon is operating this, or you are observing the video, and to pick up all the finer nuances in this. Well, my argument against this is, it is like, me observing a French film without the subtitles. The trainee is absolutely clueless what is happening, because the small maneuvers with the senior surgeon is doing, the junior doesn't have a clue about it. Now there is bothered to ask. It's like that. So the traditional approach is like this. You have to just keep observing and then learn. What is a big deal if you can just point out and say, this is how you have to do it? The surgeon will pick up very fast. The problem with this traditional approach is the sharper minds will pick up. Okay, the person who is really sharp, who is really focused can pick up. But majority of the average candidates just miss it out. Okay, so they take it years to figure out that one small trick which the surgeon would have been doing. Eventually, what it leads to the delay in the progress. So that is the sad aspect of it. So if we can share the secret to the student from the first day itself, the learning curve will be dramatically reduced. The secrets which I learned, right? Just a simple thing like, how important it is to stabilize the globe while creating your incisions. Like having an instrument, which we can stabilize the globe in a dramatic way. Initially, I was using forceps, tearing the conjunctiva, so many things, especially when doing topical anesthesia. It took few years for me to realize how important it is to have a good stabilization of the globe. It's a very simple thing, but unless until somebody points it out to you, it will be difficult. But if you're on your own, it takes years for you to learn. Similarly, with the Rexes, just having a traumatic way of stabilizing the globe, like using a second instrument through your side port and not pressing the posterior lip so the OVD doesn't leak out. This helps us to do the job pretty well. And these are all small tricks. Another aspect: always ensure that your chin and the forehead are at the same plane, the eye looking straight. These are all basic things which have to be taught to the first year resident from day one. But it takes years for us to learn them and teach them. So there's some of things which I figure out late. Important of different OVDs. You can have the dispersive OVDs or cohesive OVDs. They have a great impact in complex cases if you have PC tears and all. Even for me to understand the value, it took quite a bit of a while for me. And now I realize how invaluable they are. For example, a simple thing like, you've done a posterior capsular tear and you have to implant the lens inside. The eye is very soft in these eyes when you do vitrectomy. Okay, when you try to struggle in, it becomes difficult. The chance of the lens dropping in. Simple thing would be create space under the iris and above the anticapsule by using sodium hyaluronate. The space is very well maintained during maneuver. And because the eye is very soft, rather than struggling with your same 2.1 incision, just enlarge it a little bit, maybe 3 millimeter. That ensures that you don't have to struggle so much to get inside. So a surgeon who is he's planning his first implant in the sulcus after vitrectomy, he should be knowing this by heart, not by making so many errors and then trying to go inside and dropping few lenses inside us. And you're trying to go inside again, ensure that the bottle height is low. You have an open posterior capsule. If you go in with a bottle of 90 centimeters, everything is going to go down suddenly because there is one chamber now. So these are small things which took a time for me to learn. So mentoring does help. So most complications nowadays, I feel, if you're very averse, are preventable now. With experience, most of the complications can be prevented, but not all of them. I would like to classify unforced errors into two aspects here. We should understand why do they happen. So two aspects. One is either skill-based, that is your concepts are wrong, your skill are wrong. And second would be you don't have the skills. Necessarily, you don't have the skills. The second aspect is it is not skill-based at all. It's purely, poor decision-making. You don't have the situational awareness. Now, just let me take you through some of my own examples, which are about 10, 15 years back, which was I was ignorant. My concepts were wrong. Just like to share with you. Now, scenario one. Now, this is an intumescent cataract. The antechamber is shallowing. And I want to, deepen the chamber. So that's what is taught. You want to have a deep chamber to complete the rexus. So what do? I'm going to inject viscoelastic as has been taught to me. I'm injecting viscoelastic and it goes off. Okay. Now this shouldn't happen. The problem was my concept was wrong. This is the wrong place to inject OVD. Okay. So it took few months and few years to figure out me that what is the problem with this situation. So another similar situation where, you're going to play, push in the OVD and it's going to rip off. So the right way of injecting when you have an open capsule is to be away from the capsular tear. It has to be in the periphery, not in the center. If you just inject in the center, common sense tells us that intracapsular pressure is going to increase still further and you're going to rip off. So the small tips, if you can share to your junior, younger colleague, he doesn't have to go through all the misery which I have gone through. So some of the small tips which we have to be alert in sharing. The second scenario where this is not skill-based at all. This is one of the routine topical phaco cases, one of the fifth or sixth case that you do, and you assume everything to be normal. The patient just moves his head, okay? So here, there's nothing wrong with the skill aspect of it. It is purely, poor decision-making here. The surgeon was not aware of the situation. The patient was not hearing well, and you command something and suddenly gets startled and moves. The surgeon lacked the aware of the situation. Treat it as just as a routine. This has got nothing to do with your skill levels, just a poor decision making. So the message which I want to convey to all my budding surgeons, gen surgeons is, from day one of your residency program, I just saw a presentation on GoPro recording. See, you don't have an excuse nowadays for not having to see your recording surgeries, okay? They're very inexpensive. Record and see your own surgeries from day one. You can be your best teacher. So in this era, you may not have very large number of cases because of so many reasons nowadays. But with whatever cases you are, you can learn the surgery in a much shorter period of time with lesser number of surgeries, because information is available at your fingertips. At your fingers. Imagine 20 years back, it was like, we're cave people almost like that. So the bottom line for me is, this is a misconception that surgery cannot be taught. Surgery can be learned and it can be taught. It's the responsibility of the teachers and the students. And teachers do play a major role here. They have to, because the confidence which we have to give to the student, it is only by the teachers. And mentoring and being a teacher is a tough ask. Everybody cannot be a teacher. Everybody cannot be a trainer, because you need to have an innate passion for that. And the biggest attribute a trainer should have is patience. Nothing is more frustrating in life for an experienced surgeon to just sit and watch a resident operate. Believe me, I do this. It is one of the most frustrating aspect of your life when you see a beginner struggling. And most importantly, the mentor has to be selfless. Because if he's so miserly in sharing his secret, then you cannot call him a teacher. So the 7 commandments, I think, which for every Gen Z aspiring surgeon, these are something which I have compiled. Attitude is everything. Okay, intelligence has got nothing to do with this. Your attitude has to be wrong. It has to be right. If you don't have a right attitude, it won't help you. In that main attitude, what I mean is, patient has to be your priority. No, nobody else. You want to do the best for your patient. If you keep that one tagline close to your heart, everything will falls in place. If you are having a complication during residency period, you don't go and just continue surgery and botch up the surgery. You call your senior colleague to help you out, because you want the best to happen for a patient. Now, attitude has to continue for everybody, everything else in your step. When you're in practice, you want to do best for your patients. You buy an equipment which serves you best for the patient, not for anything else. And excellence is a habit which you have to cultivate. The great surgeon hand is a myth. Okay, the surgeon has become good because of the knowledge which is inherited by his experience or his peers' experience. So knowledge is the king. And always don't go about this flashy things about gadgets and other things. Get your basics right. So when you do fellowship under anybody, I don't want you to learn the surgical skills. I want you to learn the way your teacher is thinking. Because as I told you, the mind matters the most. So try to get into your mentor's head. What is he thinking? What is the reason why he's so successful? So you have to gain the knowledge and try to get the basics right. The most typical aspect, most important aspect is how brutally honest you are in your own self-assessment. Because I involve with a lot of trainees, and their self-assessment is so wrong. They tell me that I've already done 500 surgeries, but they wouldn't be knowing any basic thing, because their own assessment is wrong, because they still are unsure about their own competence level. That is the greatest, disservice you can do for yourself. And once you have some basics right, then you develop an art of critical thinking, that, then you start trying to be innovative, try to do better way of doing surgeries. And lastly, the most important aspect of everything, never consider yourself an expert. The day you consider yourself an expert, be sure that your downfall is just ahead of you. So with this, I think I'd like to conclude my presentation. Again, thank you so much for your attention and for having me on this wonderful program. Thank you so much.